it doesn't.
Right.
Hello, this is Dr. Ed Kim, and
Dr. Elijah Stewart.
we're going to give a little short talk on how to get most out of your experience in the operating room. So the goals and objectives of this podcast is for you to get a practical guide how to perform in the OR, how to prepare for the case, and explain what our expectations are in the pre-op setting, intra-op setting, post-op setting, and then also to understand what the culture of the behavior in the OR. So with regard to preparation, the cases should be assigned at least the day before, ideally the week before, so that you have a chance to read the patient's record, review the patient's images. I think specifically things like CTs and MRIs are good things to look at, especially with your resident, to understand the anatomy.
And the attending is happy to go over this. And also, don't be too worried if they assign the case the day of surgery, because we all get that. We understand the busy flow.
Okay. And also to review the anatomy and the procedure, there are several good resources for this, including Zollinger's Atlas, which is on Access Surgery through the UCSF Library, WebSurge, and also YouTube. So with regard to preparation, it's our expectation that you understand why the patient's having the surgery. That sounds pretty basic, but sometimes we've seen the cases where it can be a complicated case and maybe the goals of the operations are not as clear. You should also understand what major anatomical landmarks are, and there is a good YouTube video on our website that can explain this through the case of a lap chole. And then I believe, Dr. Stewart, you felt these were...
I think that, with regards to the next two, expected outcomes and potential complications, those are a little bit maybe beyond your exact scope, but it doesn't hurt to kind of start anticipating this kind of stuff and learning that stuff. Talk to your residents, think about that as you go along. And there's also resources on the Skills Lab YouTube and on the Surgery 110 playlist trajectory.
So pre-op, I think we disagree a little bit on this, or I think we do, but don't disagree. So we do. I personally like you guys to at least have to met the patient. I think it's, but you...
Yeah, I don't think it's really necessary. I think the patients sometimes are kind of stressed the day of surgery. They don't need a million people coming in, individual people. So I think for me, it would be come with the team, meet the patient as part of the team, but I don't think you need to go specifically separately. And if you don't manage to go in the morning, don't sweat it. I don't think that really is necessarily your role, because you're not a primary caregiver, you're a primary learner.
Right. I think I could agree with the group part where you go in as a group, maybe not necessarily as an individual. And then meeting the nursing staff and the anesthesiology team.
I think that's really useful.
Yeah.
Introduce yourself, get to know them. They can teach you a lot.
Right.
They have a lot to teach you.
And I think a key thing is that in the operating room, it's good for you to be helpful, to know basic skills. They may not seem like something out of a textbook, but just transferring the patient, being part of the team, learning to place a Foley catheter.
It's actually a great place to learn how to place a Foley because the patients are asleep.
Right.
So it's kind of a stress-free place to learn how to do that, so it's a good opportunity.
And I think our philosophy is that none of us is beyond any task that's necessary to get the case going and the patient taken care of. So things like compression devices, moving the gurney out of the room. I would do it. You've done it.
We all do it.
Yeah, we all do it. So I think one thing that we don't like is students just standing around and not doing anything.
But by the same token, don't feel stressed either about that. If you don't know what to do, just ask if there's something you can do to help. We just want you to come there, learn in a stress-free environment.
Yeah, and I think you can. Another thing you can do also is to pull up the imaging if the patient has had a CT scan relevant to their case. And then if there is a second computer, you might be able to write a note or try to be more efficient that way, but you don't want to get in the way of the nurse's charting. And I think this is the sign I got this off of was a Muni bus, which basically says with the driver, they'll gladly give information, but safety requires avoiding unnecessary conversation.
Yeah, I completely agree with that. And you'll be able to tell, by the tone in the room, whether it's an appropriate time to ask questions or not. Or you can even ask, can I ask a question?
Right.
But you'll be able to figure that out.
Yeah, it requires, from the attending's viewpoint, I think there's a lot of concentration that goes into even what might seemingly seem like simple cases. Because we're thinking about the case, we're thinking about what the resident is doing. There's just a lot that goes on. So if you feel like you're being ignored at times, please recognize that it's because we're focusing on the case. So I think this goes to the Intra-Op or in the operating room. I feel like the residents are the best advocates for you in terms of helping to include you in the case.
And I think it's also part of the attending's responsibility to show you the anatomy, let you feel things, sort of orient you. I think both of us need to do it. And so I think it's both of our responsibility. And so I don't feel strongly that it's one or the other.
Okay. And we definitely want you to be proactive, meaning do suctioning, retraction, cutting suture, driving a camera on a laparoscopic case. I think it's better for you to be told to back off or don't do something because you're trying to do too much than to seem disinterested. Because I think as a culture, I think you'd agree that we're a group of people who appreciates effort, action, aggressiveness, assertiveness. So even if you're not doing it right, it's better to be told that you're not doing it right than to not do it. Would you agree?
Right. Yeah, I completely agree. But also don't be afraid to say, would you like me to cut? Do you want me to use the suction? I mean,
Right.
Again, it's a dialogue. We're perfectly comfortable with you asking us this is appropriate, so don't worry about that.
And then taking a break. I think this applies to long cases, cases that can go several hours or all day. You are expected to leave for didactic sessions. We're going to try to schedule most of them in the afternoon so that you don't miss the important parts in the morning, but it can't always be done that way. And I think for long cases, it is okay to go out to do some work that you haven't finished, maybe write your notes, see your consults, follow up on some results, grab lunch, although...
But you might also just see whether a really interesting part of the case is coming up, because you might not know that you're going to go out and write that note when the most interesting part is about to occur.
Right.
So just ask, say, would this be a good time for me to go?
Yes.
Or, if you've read about the case, you kind of know what's coming,
Right.
You might be able to get a sense for it. And also, we use you guys. You guys are part of our team. We use you. You ask, are you going to need me? We're happy to have a dialogue.
Yeah, and I Warren Gasper, the vascular surgeon, was telling me how the student had to leave because of some other obligation. It was right before they were going to cross-clamp the aorta and whatnot.
Exactly.
And,
I mean, I've had the same thing where
yeah,
they leave in just before we do
Yeah.
the transhiatal dissection, which is, kind of fun.
So ask, exactly. You can time it, and we're happy to help you organize it that way. And then coming back to finish the case, I think is very important.
Absolutely do, because then there can be sometimes opportunities for you to suture, get involved. So absolutely come back, because that's an opportunity for you to practice being a surgeon.
And then at the end of the case, again, do the same thing. Help with the patient, move the patient, do the physical things, what may seem mundane, to get the case finished and patient taken care of. We expect that you write the op notes, at least with guidance of your resident if it's a complicated case, and then follow the patient post-operatively.
Yeah, you should absolutely follow him. This is the most important thing you can do after surgery. Writing the brief op note helps you kind of figure it out, and also following is key.
And I think lastly, we should conclude with the behaviors in the operating room, because I think there's certain types or level of acceptance of certain behaviors that you guys may not be you might not see as frequently on the wards. And it's primarily because it's a stressful environment, and we tend to be much more direct. And what may seem like us being abrupt actually is considered appropriate by most people who work in the OR because of what's going on and what we do. And we also tend to have long-standing relationships, and I think sometimes students can be a little bit shocked by the way we communicate with the residents. I'm not saying that we don't necessarily cross the line sometimes, but for the most part, we know our residents for years. They know that we are invested in trying to get them better. So I guess,
And also, there can be times in the operating room where seconds count. You don't have time you don't have time to really think about it. You just have you just need to direct people to get things done to make sure the patient's safe.
Yeah.
And remember, the attending's job squarely on their shoulders is the life of that patient.
Right.
They have all the responsibility for the life of that patient, them, the attending anesthesiologist, and the nurses. So that's a big responsibility, and we take it very seriously. And so if we're very direct, that's because we're trying to make sure people are alive at the end of the day, and everything's good.
Yeah, and I think so. It is a place where there are allowances, and I do remember Andy Murr, who's the chair of ENT, saying in the OR, please and thank yous are not necessarily important. It's all implied and recognized by the people who are in the team after the successful conclusion of an operation. So. And then but please do recognize that any kind of abusive language towards students is not tolerated by any of us. So there are lines, and let us know if there are any issues. But I think an operating room is where we work, where you learn what surgery is all about, so it's not a black box. So we hope you have a great experience. Thank you for listening.
Yeah, thanks for listening, and have a great learning experience.